Good afternoon. Module 5 of the C3IFT course covers cardiac assessment and basic EKGs interpretation. So a lot of this is review, and it shouldn't take you a lot of time to get through it. So we are going to talk about the cardiac conduction cycle, blood flow, and then also kind of review a little bit about cardiac output and contraction. And we're also going to prepare for the EKG, so we want to remember what those basics are and then look at 12-lead EKG acquisitions. With this too, we're also going to talk about where the ischemia is, kind of review that, and we're going to remember how to manage those patients that present to us with either angina, ischemia, myocardial infarction, or in the cases of congestive heart failure. So on review of the cardiac terminology, you have the systolic or the systole, and this is the actual contraction or the squeezing of the heart, and that's when the systemic arteries are being perfused at that point. Whereas during diastole or diastole, this is the relaxation phase, so you've gone into this relaxation and the coronary arteries are being perfused at that point. So when the heart is at rest, then the blood is trickling through those coronary arteries to feed the heart muscle itself. Then you've got the cardiac cycle, and this is one complete contraction of the heart. So we're talking about the atrial contraction, ventricle contraction. That one process is going to equal one cardiac cycle. And then your cardiac output is how much volume of blood has been pumped over 1 minute of time. So with the electrical conduction system, we start with the primary pacemaker is the pacemaker that has the fastest rate. So the primary pacemaker for the heart is supposed to be the SA node if it is functioning like it's supposed to. And it will contract at a rate of 60 to 100 beats per minute. It's normal. Of course, we know that there can be abnormalities with the SA node and it can fire slower or faster, but that is our primary pacemaker. If for some reason the SA node does not fire or refuses to work properly, then the AV node will take over. The AV node fires at a rate of 40 to 60 beats per minute. And then because the AV node and the bundle of His are very close together, that bundle of His, although, it depends on who you talk to. Some say the bundle of His doesn't have its own intrinsic rate, but per the textbooks that we utilize for the paramedic program, your bundle of His has an intrinsic rate or paced rate at 40 to 60 beats per minute as well. And again, it's because it's right there with the AV node. Now then, once that electricity travels from the bundle of His, it's going to travel down the right and left bundle branches respectively, and then up along the sides, the outsides of the heart as part of that Purkinje fibers. So the Purkinje fibers have the final little electrical kick. So if everybody above it quits working, the Purkinje fibers can actually create their own electrical impulse at a rate of 20 to 40 beats per minute. It's 20 to 40 beats per minute because the Purkinje fibers are waiting in hopes that someone higher up in the cardiac system will actually initiate the contraction so that it doesn't have to. Because if you think about it, the Purkinje fibers are down here on the biggest part of the heart. They're going to have to do a big amount of muscle contraction to make that happen. So it really needs some electrical kick from above to help that contraction be nice and full and solid. So that's why when you look at the EKG strip and it's a rate of 20 to 40, the QRS is wider because it's occurring down in the ventricles. It's taking more effort. Now with the cardiac cycle, of course, you have the P wave, and the P wave is indicative of the atria is depolarizing. The QRS is about the ventricles, and then the T wave is about repolarization. So let me flip this slide. So with the cardiac cycle here, you can see that the P wave indicates that little tiny bit of atrial contraction that occurs. So it's a little tiny wave, and then the ventricles contract and it creates that big, large QRS complex. When the ventricles repolarize, when that electricity repolarizes, that's what creates the T wave, and it repolarizes in reverse order. So that's why you see the contraction going this way but then it turns around and it repolarizes back. So that's why it travels back up the system. So it goes from the Purkinje's and it travels back up the line, up the bundle branches. So our PR interval should be 0.12, but it should be no greater than 0.20. So the PR interval should be no greater than 0.20. The QRS complex should be no greater than 0.12. And when we look at blood flow through the heart, you know that the blood is coming in through the inferior and the superior vena cava. It's traveling into that right atrium. The atrias contract. It shoots the blood through the tricuspid valve and into that right ventricle. The ventricle contracts and shoots the blood through the semilunar valve out the pulmonary arteries into the lungs, where it's going to pick up oxygen. From the lungs, it's going to travel back to the heart through the pulmonary vein. Remember, arteries go away from the heart, veins come to the heart. So it comes back through the pulmonary vein, drops into the left atria. The atria, again, it contracts, shoots the blood through that bicuspid or mitral valve and into that left ventricle. The left ventricle contracts, shoots blood out through the aortic semilunar valve, and then that moves it out through the aorta and into circulation. So here's a nice picture to kind of show you how that heart sits, and it also provides you with a picture of the coronary arteries, which is our big concern in our myocardial infarction patients, is trying to identify or isolate the location of the infarction. So when we talk about the basic heart sounds, you have two basic heart sounds. You have a lub and a dub. Those are our basic heart sounds. The lub is the S1 heart sound. So it's S1 lub, S2 dub. And with the S1, what you're hearing is the mitral and the tricuspid valve closing. So you have the closure of the valves between the atrias and the ventricles. So you're hearing those valves shut. And it's kind of, it's very, there was a video that I watched that I really thought did a great job of trying to explain this. When you talk about heart sounds don't correlate with the contraction exactly, because you're hearing the sound after the action has occurred. So if we're sitting here in the room and we hear the door shut, that we turn and look because we don't know who walked out the door, because we responded after we heard the sound. So the door shutting and then the noise came after. So the door shuts, the noise from the door shutting, we turn and look. So the S1, that lub sound, is what we're hearing at the closing of the tricuspid and the mitral valves. Then we have the S2 heart sound, and this is our dub. So you have your lub dub. The dub is when the pulmonic and aortic valves are closing, and that occurs more during the diastole because it's part of that relaxation phase. So again, that's hearing the door close, or the door closes, you hear the noise, that's the dub. So the doors have closed, those valves have closed off, then you hear the dub. So that's your S1, S2 heart sound. So the significance to a 12 lead and why blood flow is so important. Anatomically, depending on the area of the heart that's been affected by an infarct or ischemia, we can predict either signs or, symptoms or diagnosis based on their clinical presentation. So looking at left ventricular failure, you can actually identify in an EKG strip if you have ventricular hypertrophy or enlargement of the ventricles as a result of CHF. In the 12 lead, you can actually identify that. Or it could be that you have something like a right ventricular infarction where you see the damage occurring in a certain spot on the 12 lead, and that tells you that the area of infarction is in that right ventricle. So why are the heart sounds important? Well, we may never be good at abnormal heart sounds, but if we know what is normal, then we are more able to identify the things that are abnormal. So there's lots of different, there's murmurs, clicks, there's an S3 and S2, all of which have their own clinical diagnoses associated with them. And if you talk to anyone who's went through physicians that have gone through school, talk about how they still, as physicians, have difficulty in identifying and understanding what they're hearing with the heart sounds. So by and far, we do not expect EMS personnel to be professionals and be able to be right on key with heart sounds. The S3 and S4 are very important. You may have heard it in school, the Tennessee or the Kentucky. And I think I've found a way that does it better. If you hear an S3 is a sloshing in. And you can hear it when you're listening to the heart sounds. You can hear sloshing in. Instead of lub-dub, you hear lub-dub-da, lub-dub-da. And that's that sloshing in. And the sloshing, if you think about fluid, the S3 heart sound indicates congestive heart failure. Now an S4 heart sound is a stiff wall, a stiff wall. So the abnormal sound comes before the lub-dub. So a stiff wall. And that tells you that there's a myocardial infarction. If you think about a part of the wall that's not working like it should because it's not getting the oxygen, so it's not going to contract, the wall's going to be stiff, a stiff wall. So an S4 heart sound indicates a myocardial infarction. When it comes to cardiac output, we're talking about the amount of blood that's pumped by the ventricles in a given unit of time, and we're looking at cardiac output as equaling the stroke, sorry, ooh, I think I had an own stroke. Cardiac output is stroke volume times the heart rate. Now typically in 1 minute of time, the normal amount contracted and released by the heart is 4 to 8 liters per minute. But your cardiac output is all about stroke volume, how much blood is actually entering the ventricle and being ejected with each beat, and then the heart rate and how fast the heart is beating to get that blood out. So cardiac output is dependent on 2 factors, stroke volume and heart rate. Cardiac output also talks a lot about the dependency on preload, afterload, and the heart's contractility, or the ability of the heart to contract. So with preload, we're talking about the volume at the end of diastole, so how much has been dumped in and is sitting in there, and how much is actually coming up from the inferior vena cava, from the lower part of the body, that's able to be dropped in and returned to the heart. So that's what we're referencing when we talk about preload. And then afterload is how much pressure or how much resistance the heart has to contract against to get that blood out the aorta. So that's systemic vascular resistance, the resistance against which the left ventricle must pump to get the blood out. So you also have contractility. If the heart is stretched out, we talked about the cardiac enlargement, the enlarged heart. If you have that increased size, it actually weakens the heart and the contractility isn't as good. So a lot of times you'll see those patients are prescribed medications to improve the contractility of the heart to help it be able to pump. So problems that are associated with cardiac output, we talk about hypovolemia. This can be the result of hemorrhage. It could be the result of burns because you have such a fluid shift, the third space shifting in burns. It could be that you have someone who's been vomiting excessively, so they have that hypovolemia as a result of the vomiting. And it can also be a space issue, a space shock issue, like your neurogenic shock and sepsis. And then also cardiac output can be tweaked or adjusted based on heart rate. So if you have someone who's tachycardic, that can have an effect on the cardiac output just as much as bradycardia can. So if you have someone whose heart rate is low, maybe they've taken CNS depressants, they've been taking a medication that has dropped their respiratory rate, the next thing you know, you'll see the heart rate's going to drop as well. All of that can impact the amount of cardiac output that's put through the system. Arrhythmias such as atrial fib, your heart blocks, supraventricular tachycardia or SVT, and cases such as Wolff-Parkinson-White can have an impact on cardiac output and how much volume of blood is actually being sent through the body. Other conditions such as mitral stenosis or any type of insufficiency can have an impact. Conditions like cardiac tamponade or any type of pericarditis where you have that inflammation, maybe it's the result of some sort of infection or cardiac tamponade, can cause problems with cardiac output just as much as the restrictive cardiomyopathy. And some pump issues include angina and MI. So again, we're talking about problems that can impact the cardiac output. You have someone who has angina and MI, then the heart muscle is not going to contract and release that blood like it should. And also, again, we mentioned before the congestive heart failure. And then also in cases where you have patients that have been impacted by trauma, whether that be a direct or an indirect impact as a result of maybe a secondary injury. And contractility refers to the strength of the cardiac muscle contraction. So contractility has both an active and a passive component to it. The active contractility refers to the increase in the contraction strength that is derived from the stimulation of the sympathetic nervous system that's innervating the heart muscle. Whereas passive contractility, that deals with the rubber band theory. So that's Frank Starling's law, more in, more out. So if we get it stretched out there, it's going to have a passive contractility where it will return to its resting length as a result of that recoil. And we are going to take just a slide or two to review the basics of EKG interpretation. So with EKG interpretation, we want to ask a few questions. I always start is, what is the rate? Because it's the easiest thing that I can teach students to start out with. So what is the rate, and then what is the rhythm? Does the ball bounce regularly across, or is there some irregularity in it? And then we start looking at the specifics. So we know that the P wave is part of atrial contractions. Do you have P waves present? Are they upright or are they inverted? And what is your PR interval? Is it 0.20 or is it greater than 0.20? And is there some consistency or is it irregular? And then you ask yourselves the question, well, do I have a QRS complex, and is the width of the QRS complex within normal range? Is it less than 0.12 or greater than 0.12? And when it comes to 12-lead EKG acquisition, we want to make sure that the patient is positioned properly to start out with. So we want them to be in a supine position. That is our best choice. But if the patient is really sick, we can go into the Fowler's position. We want to make sure that the skin is dry, and if it's not dry, we want to make it so. And also we want to make sure that the electrodes have a good solid connection to the chest wall, so we want to shave that patient if necessary. And we want to make sure that our placement of the leads is appropriate. So we're looking both at limb leads and the precordial leads. So our limb leads are the result of the primary chest leads that we deal with on a typical daily basis to get lead 2 EKG acquisition. So we look at the RA, LA, so you have your right arm and left arm, that's your white and your black, and then your left leg is going to be the red, and then your RL is green. I always say that green is grass, the white on right, smoke over fire, green is grass. Green is our ground, so that's the right leg. And the limb leads have to go on the limbs when you're doing the EKG for 12-lead purposes. So we definitely want to make sure that they're placed on the limbs appropriately so that we get those EKG interpretations accurately. And then the precordial leads involve V1 through V6, and the placement of those leads are very, very particular. So in V1, we're placing it in the fourth intercostal space, right of the sternum, whereas V2 is left of the sternum on the fourth intercostal space, and V3 actually goes between V2 and V4. So we always place V3 after we place V4. So we're going to place V1, V2, place V4 at the midclavicular line at the fifth intercostal, and then place V3 in between V2 and V4. Then we move down and we're going to place V6. V6 goes mid-axillary, so we're looking at that armpit line, and it goes in that fifth intercostal space, so it's running on the same line as your V4. And then you're going to place V5 in between those two. So that's the best way to get the best acquisition. So again, this is just a pictorial representation to kind of give you an idea. It's really hard sometimes with artistic rendering. It looks like they're almost curved, but in reality you're making a straight line through that intercostal space. So we're going to talk a little bit about coronary artery perfusion and how to localize or identify the location of an MI. So when we take a look at the picture here, you can actually see that you have a right and a left coronary artery, and those two coronary arteries are the only ones we have that actually exit from the aortic arch and feed the entire heart. So you have the right coronary artery that comes down, it wraps around on the right side of the heart, whereas the left coronary artery comes down and it actually splits rather quickly into a circumflex that wraps around the back side of the heart, and then you have the left anterior descending that travels down the front of the heart. And I think also it is a good idea to understand a little bit about the anatomy component. That left anterior descending artery is considered that center point where the septum is located in the ventricles. So if you would go to dissect the heart, you would actually use that left anterior descending as the landmark to know exactly how to cut so that you can cut through and see where the septum is. You're actually hitting the septum between the right and left ventricle. So the right coronary artery is responsible for supplying blood flow to the right atria, the right ventricle, and the inferior wall of the left ventricle. And it divides into the posterior descending coronary artery, blah, blah, blah. The big thing here is that you understand that it's feeding the right side of the heart and the inferior wall on the left ventricle, and it is responsible for supplying blood to our SA and our AV nodes in the majority of our patients. And this gives us some specificity on that. So the right coronary artery supplies blood to the SA node in 55% of the population and 90% of the population to the AV node. Then you have the left coronary artery, and as I mentioned, it does bifurcate rather quickly into a circumflex artery and an anterior descending artery. That left anterior descending is the primary branch that supplies 40% to the left ventricle, and it's known as the widowmaker because it's right there at the septum. It's feeding the blood supply to the anterior and septal walls of the left ventricle, and it supplies the bundle of His and both the bundle branches with the blood it needs in order to allow the electricity to conduct and pass through. Now the left circumflex artery, that passes around and goes to the back side of the heart, and that's where, if you were wondering earlier where the blood supply comes to for the 45% of the population that doesn't get it from the right coronary, it actually comes from that circumflex branch where it wraps around the back side and feeds the SA node in 45% of the population and 10% in the AV node. So the importance of this, it gives you the ability to identify where the MI is located, what vessel has been damaged, and it'll give you a really good idea of what to expect with your patient and how they're going to present to you and what you can do to help them or prevent further damage, because some medications are not appropriate in certain situations. So how to tell if they're having the big one? Well, here we go. It does not include descriptions or examples of conditions or disease processes that may interfere with the ability to read or interpret the EKG. Your paramedics that are interested in ECG interpretation should consider the CCT course or a specific 12-lead EKG program. So what they're doing here is they're just going to provide you with the information you need to identify the areas of ischemia or infarction. This slide goes into a great amount of depth, but what I'm going to tell you is this. In order to find the ischemia or infarction in an EKG interpretation, you have to find your baseline, that's the point at which the isoelectric line is, and you want to identify the J point. I'm going to show you that in a slide, and then you're going to move backwards into the EKG, and that's going to kind of let you see if there's changes in the ST segment that lie either above or below that isoelectric line. So hold on one second, we're going to get into this. So first and foremost, this slide shows you about the finding of the J point. So the J point exists wherever where the very last point at which it comes to the isoelectric line. So you can kind of see the J point and how you have that initiation of the Q, it goes up into the R, then you come down into the S, and then into the T, and that T, that's your that final point when it moves from the QRS complex and moving into the T, that's your J point. I'm trying to think how I want to do this. This just kind of shows you the J point. This slide really doesn't do much. Let me move to the next slide so you can see it. Hold on one second. So I don't believe this is really the best slide to do this type of presentation with, but it's what the state provided us. I am going to provide you with some other PowerPoint presentations that I've done that may give you a little bit more clarity if you have problems identifying the J point. But in this picture here you can actually see where the Q, it drops into the R, and then you move up into the S, and you see a little bit of an upstroke or a little slur up, and that's moving your S into your T wave, and that's so very high. If you look at that line that's running across, that little line that they have across, that's your isoelectric line. That's what you're basing this against. If you look at that isoelectric line and then you look up to see where that J point is, you'll see that is extended above the isoelectric line. If the QRS was going to do this and be inverted like it is, it should have stopped and came back to our isoelectric line and been right there. But because it extends up and goes beyond the isoelectric line, that tells us that we have an ST segment elevation here. So this is where your ST elevation is. And in finding an MI, the best way to do it is the ICL leads theory, and that kind of gives us an idea of what part of the heart is involved. So let's take a look. So in the ICL leads, the I, of course, is for inferior, and that involves leads 2, 3, and AVF. So if you looked in lead 2, 3, and AVF of this EKG strip, you would see that there is ST segment elevation because it is above the isoelectric line, or above that electrical baseline. So that is confirming that this is an inferior wall MI, and we can further reconfirm it by looking in leads 1 and AVL, where we have the reciprocal depression. And again, this presentation is not meant to teach you all the skills. It's expecting you to already know some of these skills going into this lecture. So if you have any questions or concerns at all, you can always check out the other PowerPoint presentations and become more familiar and more comfortable with them. Now the second part of the ICL leads is the S, and that's your septal wall, and that involves V1 and V2, and it also moves into the anterior, so I see all, and A for anterior. So a lot of times you'll see septal and anterior wall MIs together, but you can actually see both in V1 and in V2 your J point is well above the isoelectric line, the ST segment is above the isoelectric line, and that is telling you that you have ST elevation in V1, V2, and also in V3 on this particular slide. And there's your anterior, so that's, again, you can see the ICL leads V3 and V4 is the anterior wall, and you can see that you have ST segment changes in V3 and V4 both. And then your lateral wall, apparently they didn't have an EKG strip for the lateral infarction, but your lateral wall involves V5, V6, and then 1 in AVL, and they consider 1 in AVL to be the high lateral wall, but that's where you're looking for changes. And you can actually see changes in this particular EKG in V5 and V6. You can see the ST segment that has elevated above the J point. So management discussion, we're going to talk about angina patients, those patients that are suffering from an MI and congestive heart failure. So angina is very similar to an MI, except angina is typically a chronic problem that is exertion related. It's induced based on exertion. And with angina, rest will improve it. It can be treated with nitroglycerin, and it's transient in nature. So when would you see this patient in the BITP or the CI? I don't know why they have B there. The critical. I don't know why they have B there. All right. Anyway, when would you see this patient in the C3 setting? Is if you're transferring them from the catheter lab or ER and you're trying to get them to higher level care. So an acute MI should always consider air transport first, and then CCT ground if time permits. Remember that time is muscle, and we want to consider the presentation, the location of the MI, and anticipate the needs. But we definitely want to make sure that the patient has oxygen, IV establishment. There is a preference for 2 lines in this case. We want to monitor the patient and make sure that we are evaluating their pulse oximetry. Consider nitroglycerin. You may see on the interfacility transfer that they have heparin drips involved, and monitor for hemorrhage if they've administered any thrombolytics prior to your arrival to transport that patient, and accurately assess, document, and manage any pain that patient continues to feel. Now with a congestive heart failure, of course, it's about the heart not pumping adequately anymore. So the input is greater than the output, and the result of that is increased pressure. That increased pressure starts backing up the line, and unfortunately it backs up into the lungs. So there's 2 types. I always tell people that they need to consider CHF in pieces, because you have a right-sided heart failure, you have a left-sided heart failure, and then you just have a global category of congestive heart failure. The most common cause of right-sided heart failure is left-sided heart failure, but it can also be the result of COPD in the cases where patients have pulmonary hypertension, or what's referred to as cor pulmonale. And right-sided heart failure can also be seen if you have an MI. But the systemic backup, because it's the right side of the heart that's failing to pump properly, it's going to back fluids up into the dependent areas. So if they're standing up and moving around, it's going to be in their ankles and in their legs. If they're laying in bed, it's going to be in their sacrum, so it's going to be in their back. And the lung sounds on a right-sided heart failure patient should be dry, because the problem is before the lungs. The problem is backing up the line before it reaches the lungs, so it's going to have dry lungs, and that's important to remember. With left-sided heart failure, your lungs are going to be full of fluid, because it's going to back from the left side into the lungs. It's going to drop into that. So you may not have, with left-sided heart failure, you may not see pedal edema or sacral edema. You may not have that. So the most common cause of left-sided heart failure is untreated, uncared for chronic hypertension. And it again, also with the MIs, it can lead into that, but it causes the pulmonary edema. So they have the thick, wet lungs. They'll have the real bad wet lung sounds. And then when CHF continues, if that left-sided heart failure continues and it's not treated and cared for, it's going to eventually back up into the right side of the heart, and that's when you see right-sided involvement. So you went from left-side heart failure to right-side heart failure, and now you have congestive heart failure as a whole. So with a congestive heart failure patient that's been in exacerbation, you're going to see shortness of breath. They're going to have positional shortness of breath, so they're going to have orthopnea. If they try to lay flat, their lungs are going to fill up with fluid and they're not going to be able to breathe. Pulmonary edema, you may even see again the pedal and sacral edema, particularly if we're dealing with complete congestive heart failure. You'll see jugular vein distension as well, because not only is it backing up the right side and out, but you're also going to see it in jugular vein distension. They'll be pale and diaphoretic as well because the fight or flight is trying to kick in. But your general treatment is to calm and reassure the patient. Make sure that you're transporting them in a upright position so that they can definitely have the space to breathe. We want to provide them oxygen. We can consider CPAP with this patient. This is something that wasn't available when these slides were created, so CPAP is really good with our CHF patients. If you have a non-rebreather bag valve mask, and again, the bag valve mask was on the theory that you're doing that positive pressure ventilations that you would see with a CPAP machine. But the bag valve mask is very uncomfortable, it's awkward, and it's very hard to do with a patient who is alert and not appreciating you in their face. If worse comes to worse, you can always consider intubation with that patient, but as a last resort. CPAP has been found to be very beneficial in these patients. But you want to continue your EKG monitoring, blood pressure and oxygen sat, and then you also want to consider some medications to reduce the workload on the heart and create some vasodilation to allow the blood to be able to pass easier. So we're looking at medications such as nitro and morphine to potentiate the effects of nitro, and then also look at our diuretics. So we're talking about Lasix and perhaps albuterol to help the bronchodilation to kind of move that through. So this concludes the cardiac section of the C3IFT module. I hope that you were able to kind of work through this. Again, I'm going to try to provide you with some additional resources in case you are not comfortable with the way this presentation went, because it went through it based on the premise that everyone taking the class has already had a good solid foundational education in it. You may or may not have. If you didn't, you can always refer to those additional slides that I'm going to provide you. If you have any questions or if you need additional help, please feel free to stop by my office anytime. Have a great day.